Welcome back. In this session, let us discuss the principles of drug therapy, distribution, metabolism and excretion of drugs. First, let us see drug distribution. Drug distribution is the process by which a drug reversibly leaves the bloodstream and enters the interstitium or extracellular fluid and the tissues. For drugs administered intravenously, absorption is not a factor, and the initial phase from immediately after administration through the rapid fall in concentration represents the distribution phase, during which the drug rapidly leaves the circulation and enters the tissues. The distribution of a drug from the plasma to the interstitium depends on cardiac output and local blood flow, capillary permeability, the tissue volume, the degree of binding of the drug to plasma and tissue proteins, and the relative lipophilicity of the drug. Blood flow. The rate of blood flow to the tissue capillaries varies widely. For instance, blood flow to the vessel-rich organs like brain, liver and kidney is greater than to the skeletal muscles. Adipose tissue, skin and viscera have still lower rates of blood flow. Variations in blood flow partly explains the short duration of hypnosis produced by an intravenous bolus dose of propofol. High blood flow together with high lipophilicity of propofol permits the rapid distribution into the central nervous system and produces anesthesia. A subsequent lower distribution to skeletal muscle and adipose tissue lowers the plasma concentration, so that the drug diffuses out of the central nervous system down the concentration gradient and consciousness is regained. Capillary permeability. Capillary permeability is determined by capillary structure and by the chemical nature of the drug. Capillary structure varies in terms of the fraction of the basement membrane exposed by slit junctions between endothelial cells. In the liver and spleen, a significant portion of the basement membrane is exposed due to large discontinuous capillaries through which large plasma proteins can pass. In the brain, the capillary structure is continuous and there are no slit junctions. To enter the brain, drugs must pass through the endothelial cells of the CNS capillaries or be actively transported. For example, a specific transporter carries levodopa into the brain. By contrast, lipid-soluble drugs readily penetrate the CNS because they dissolve in the endothelial cell membrane. Ionized or polar drugs generally fail to enter the CNS because they cannot pass through the endothelial cells that have no slit junctions. Those closely juxtaposed cells from tight junctions that constitute the blood-brain barrier. Binding of drugs to plasma proteins and tissues. Binding to plasma proteins. Reversible binding to plasma protein sequesters drugs in a non-diffusible form and slows their transfer out of the vascular compartment. Albumin is the major drug binding protein and may act as a drug reservoir. As the concentration of free drug decreases due to elimination, the bound drug dissociates from the protein. This maintains the free drug concentration as a constant fraction of the total drug in the plasma. Now let us see binding to tissue proteins. Many drugs accumulate in tissues, leading to higher concentration in tissues than in the extracellular fluid and blood. Drugs may accumulate as a result of binding to lipids, proteins or nucleic acids. Drugs may also be actively transported into the tissues. Tissue reservoirs may serve as a major source of the drug and prolong its actions or cause local drug toxicity. For example, acrolein, the metabolite of cyclophosphamide, can cause hemorrhagic cystitis because it accumulates in the bladder. Lipophilicity. The chemical nature of a drug strongly influences its ability to cross the cell membranes. Lipophilic drugs readily move across most biologic membranes. These drugs dissolve in the lipid membranes and penetrate the entire cell surface. The major factor influencing the distribution of lipophilic drugs is blood flow to the area. In contrast, hydrophilic drugs do not readily penetrate cell membranes and must pass through slit junctions. Volume of distribution. The apparent volume of distribution, or VD, is defined as the fluid volume that is required to contain the entire drug in the body at the same concentration measured in the plasma. It is calculated by dividing the dose that ultimately gets into the systemic circulation by the plasma concentration at time 0. Thus, VD equals A by C, where A is the amount of drug in the body and C is the plasma concentration. Although VD has no physiologic or physical basis, it can be useful to compare the distribution of a drug with the volumes of the water compartments in the body. Now, let us see the distribution of drugs into the water compartments in the body. Once a drug enters the body, it has the potential to distribute into any one of the 3 functionally distinct compartments of body water or to become sequestered in a cellular site. Plasma compartment. If a drug has a high molecular weight or is extensively protein bound, it is too large to pass through the slit junctions of the capillaries and thus is effectively trapped within the plasma or vascular compartment. As a result, it has a low VD that approximates the plasma volume of about 4 liter in a 70 kg individual. Apparent shows this type of distribution. Extracellular fluid. If a drug has a low molecular weight but is hydrophilic, it can pass through the endothelial slit junctions of the capillaries into the interstitial fluid. However, hydrophilic drugs cannot move across the lipid membranes of cells to enter the intracellular fluid. Therefore, these drugs distribute into a volume that is the sum of the plasma volume and the interstitial fluid, which together constitute the extracellular fluid, about 20% of body weight or 14 liter in a 70 kg individual. Aminoglycoside antibiotics show this type of distribution. Total body water. If a drug has a low molecular weight and is lipophilic, it can move into the interstitium through the slit junctions and also pass through the cell membranes into the intracellular fluid. These drugs distribute into a volume of about 60% of body weight or about 42 liter in a 70 kg individual. Ethanol exhibits this apparent VD. Apparent volume of distribution. A drug rarely associates exclusively with only one of the water compartments of the body. Instead, the vast majority of drugs distribute into several compartments, often avidly binding cellular components such as lipids, which is abundant in adipocytes and cell membranes, proteins abundant in plasma and cells, and nucleic acids abundant in cell nuclei. Therefore, the volume into which drugs distribute is called the apparent volume of distribution, or VD. VD is a useful pharmacokinetic parameter for calculating the loading dose of a drug. Determination of VD. The fact that drug clearance is usually a first order process allows the calculation of VD. First order means that a constant fraction of the drug is eliminated per unit of time. This process can be most easily analyzed by plotting the log of the plasma drug concentration, or Cp, versus time. The concentration of drug in plasma can be extrapolated back to time 0, the time of intravenous bolus, on the y-axis to determine C0, which is the concentration of drug that would have been achieved if the distribution phase had occurred instantly. This allows the calculation of Vd as Vd equals dose by C0. For example, if 10 mg of drug is injected into a patient and the plasma concentration is extrapolated back to time 0 and C0 equals 1 mg per liter, then Vd equals 10 mg by 1 mg per liter, which is equal to 10 lit. Effect of Vd on drug half-life. Vd has an important influence on the half-life of a drug because drug elimination depends on the amount of drug delivered to the liver or kidney or other organs where metabolism occurs per unit of time. Delivery of drug to the organs of elimination depends not only on blood flow but also on the fraction of the drug in the plasma. If a drug has a large Vd, most of the drug is in the extraplasmic space and is unavailable to the excretory organs. Therefore, any factor that increases Vd can increase the half-life and extend the duration of action of the drug. An exceptionally large Vd indicates considerable sequestration of the drug in some tissues or compartments. In this figure, you can see the drug concentrations in plasma after a single injection of drug at time equals 0. A, concentration data are plotted on a linear scale and B, concentration data are plotted on a log scale. Now let us see drug metabolism or biotransformation in detail. Biotransformation is the process of biochemical alteration of the drug in the body. Body treats most drugs as foreign substances and tries to inactivate and eliminate them by various biochemical reactions. These processes convert the drugs into more polar water soluble compounds so that they are easily excreted through the kidneys. Some drugs may be excreted largely unchanged in the urine. Example, furosemide and atenolol. Now let us see the enzymes in biotransformation. The biotransformation reactions are catalyzed by specific enzymes located either in the liver microsomes, microsomal enzymes, or in the cytoplasm and mitochondria of the liver cells, and also in the plasma and other tissues, which are non-microsomal enzymes. Reactions of drug metabolism. The kidney cannot efficiently eliminate lipophilic drugs that readily cross cell membranes and are reabsorbed in the distal convoluted tubules. Therefore, lipid soluble agents are first metabolized into more polar or hydrophilic substances in the liver through two general sets of reactions called phase 1 and phase 2. This can be seen in figure 8. In phase 1, the phase 1 reactions convert lipophilic drugs into more polar molecules by introducing or unmasking a polar functional group such as an hydroxyl or amine group. Phase 1 reactions usually involve reduction, oxidation or hydrolysis. Phase 1 metabolism may increase, decrease or have no effect on pharmacological activity. Phase 1 reactions utilizing the P450 system. The phase 1 reactions most frequently involved in drug metabolism are catalyzed by the cytochrome P450 system, also called microsomal mixed function oxidases. The P450 system is important for the metabolism of endogenous compounds such as steroids and lipids, and for the biotransformation of exogenous substances or xenobiotics. Cytochrome P450, designated as CYP, is a superfamily of heme containing isozymes that are located in most cells, but primarily in the gastrointestinal tract and liver. 4 isozymes are responsible for the vast majority of P450 catalyzed reactions. They are CYP3A 4 or 5 36%, CYP2D 6 19%, CYP2C 8 or 9 16%, and CYP1A 2 11% and the rest. Oxidation. The process of addition of oxygen or negatively charged radical to a drug molecule or removal of hydrogen or a positively charged radical from a drug molecule is oxidation. Oxidation reactions are the most important metabolizing reactions, mostly catalyzed by monooxygenases present in the liver microsomes. They are carried on by a system which includes cytochrome P450, NADPH and molecular oxygen. There are several types of oxidation reactions like hydroxylation. Examples are salicylic acid to gentisic acid, phenytoin to hydroxyphenytoin. Deamination. Examples are amphetamine to benzyl methyl ketone, S-oxidation where example is cimetidine to cimetidine sulfoxide, dealkylation, example imipramine to desmethylimipramine, codeine to morphine. Oxidation can also be catalyzed by non-microsomal enzymes. Example, ethyl alcohol gives CO2 plus H2O. Reduction may be catalyzed by microsomal or non-microsomal enzymes. There are many types of reduction reaction. Nitro reduction, example is chloramphenicol to aryl amine. Keto reduction, example corticosterone to hydrocortisone. Phase 1 reactions not involving the P450 systems. These include amine oxidation, for example oxidation of catecholamines to histamines, alcohol dehydrogenation, for example ethanol oxidation, esterases, for example metabolism of aspirin in the liver, and hydrolysis, for example of procaine. Hydrolysis is the process where a drug molecule is split by the addition of a molecule of water. Esterases, amidases and peptidases catalyze hydrolytic reactions. Example, acetylcholine plus water gives choline plus acetic acid. Phase 2 reactions. This phase consists of conjugation reactions. If the metabolite from phase 1 metabolism is sufficiently polar, it can be excreted by the kidneys. However, many phase 1 metabolites are still too lipophilic to be excreted. A subsequent conjugation reaction with an endogenous substrate such as glucuronic acid, sulfuric acid, acetic acid or an amino acid results in polar, usually more water soluble compounds that are often therapeutically inactive. A notable exception is morphine 6 glucuronide, which is more potent than morphine. Glucuronidation is the most common and the most important conjugation reaction. Drugs already possessing an OH-NH2 or carboxylic group may enter phase 2 directly and become conjugated without prior phase 1 metabolism. The highly polar drug conjugates are then excreted by the kidney or in bile. Drug elimination. Once a drug enters the body, the process of elimination begins. The three major routes of elimination are hepatic metabolism, biliary elimination and the urinary elimination. Together, these elimination processes decrease the plasma concentration exponentially. That is, a constant fraction of the drug present is eliminated in a given unit of time. Most drugs are eliminated according to first order kinetics, although some such as aspirin in high doses are eliminated according to zero order or non-linear kinetics. Metabolism leads to production of products with increased polarity, which allows the drug to be eliminated. Clearance or CL estimates the amount of drug cleared from the body per unit of time. Total clearance is a composite estimate reflecting all mechanisms of drug elimination and is calculated as follows. CL is equal to 0.693 into Vd by T half, where T half is the elimination half-life. Vd is the apparent volume of distribution and 0.693 is the natural log constant. Drug half-life is often used as a measure of drug CL because for many drugs Vd is a constant. Drugs must be sufficiently polar to be eliminated from the body. Removal of drugs from the body occurs through a number of routes, the most important being elimination through the kidney into the urine. Patients with renal dysfunction may be unable to excrete the drugs and are at risk for drug accumulation and adverse effects. Now, let us see in detail the renal elimination of a drug. Elimination of drugs through the kidneys into urine involves the process of glomerular filtration, active tubular secretion and passive tubular reabsorption. Glomerular filtration. Drugs enter the kidney through renal arteries which divide to form a glomerular capillary plexus. Free drug not bound to albumin flows through the capillary, slits into the Bowman space as part of the glomerular filtrate. The glomerular filtrate rate or GFR is normally about 125 ml per minute but may diminish significantly in renal disease. Lipid solubility and pH do not influence the passage of drugs into the glomerular filtrate. However, variations in GFR and protein binding of drugs do affect this process. Proximal tubular secretion. Drugs that were not transferred into the glomerular filtrate leave the glomeruli through efferent arterioles which divide to form a capillary plexus surrounding the nephric lumen in the proximal tubule. Secretion primarily occurs in the proximal tubules by two energy requiring active transport systems. 1,4 anions, for example, deprotonated forms of weak acids, and 1,4 cations, for example, protonated forms of weak bases. Each of these transport systems show low specificity and can transport many compounds. Thus, competition between drugs for these carriers can occur within each transport system. Premature infants and neonates have an incompletely developed tubular secretory mechanism and thus may retain certain drugs in the glomerular filtrate. Now, let us see distal tubular reabsorption. As a drug moves towards the distal convoluted tubule, its concentration increases and exceeds that of the perivascular space. The drug, if uncharged, may diffuse out of the nephric lumen back into the systemic circulation. Manipulating the urine pH to increase the fraction of ionized drug in the lumen may be done to minimize the amount of back diffusion and increase the clearance of an undesirable drug. As a general rule, weak acids can be eliminated by alkalinization of the urine, whereas elimination of weak bases may be increased by acidification of the urine. This process is called ion trapping. For example, a patient presenting with phenobarbital weak acid overdose can be given bicarbonate which alkalizes the urine and keeps the drug ionized, thereby decreasing its reabsorption. Now, let us see the role of drug metabolism. Most drugs are lipid soluble and without chemical modification would diffuse out of the tubular lumen when the drug concentration in the filtrate becomes greater than that in the perivascular space. To minimize this reabsorption, drugs are modified primarily in the liver into more polar substances through phase 1 and phase 2 reactions. The polar or ionized conjugates are unable to back diffuse out of the kidney lumen. Faecal and biliary excretion. Unabsorbed portion of the orally administered drugs are eliminated through the fecus. Liver transfers acids, bases and unionized molecules into bile by specific and transport processes. Large water soluble conjugates are excreted in the bile. Some drugs may get reabsorbed in the lower portion of the gut and are carried back to the liver. Such recycling is called enterohepatic circulation and it prolongs the duration of action of the drug. Example, chloramphenicol, tetracycline, oral contraceptives and erythromycin. Pulmonary excretion. the lungs are the main route of elimination for gases and volatile liquids like in general anesthetics and alcohol. This also has legal implications in medico-legal practice. Now, let us see the clearance by other routes. Drug clearance may also occur through the intestines, bile, lungs and breast milk among others. Drugs that are not absorbed after oral administration of drugs that are secreted directly into the intestines or into bile are eliminated in the fecus. The lungs are primarily involved in the elimination of anesthetic gases, for example, isoflurane. Elimination of drugs in breast milk may expose the breastfeeding infant to medications or metabolites being taken by the mother and is a potential source of undesirable side effects to the infant. Excretion of most drugs into sweat, example iodide and rifampicin, saliva, example phenytoin and clarithromycin, metallic taste with metronidazole, metoclopramide and disulfiram. Tears, hair and skin occurs only to a small extent. Total body clearance and drug half-life are important measures of drug clearance that are used to optimize drug therapy and minimize toxicity. Now, let us see total body clearance. The total body or systemic clearance CL total is the sum of all clearances from the drug metabolizing and drug eliminating organs. The kidney is often the major organ of elimination. The liver also contributes to drug clearance through metabolism or excretion into the bile. Total clearance is calculated using the following equation. CL total is equal to CL hepatic plus CL renal plus CL pulmonary plus CL other, where CL hepatic plus CL renal are typically the most important. Now, let us see the clinical situations resulting in changes in drug half-life. When a patient has an abnormality that alters the half-life of a drug, adjustment in dosage is required. Patients who may have an increase in drug half-life include those with diminished renal or hepatic blood flow, for example, in cardiogenic shock, heart failure or hemorrhage, or decreased ability to extract the drug from plasma, for example, in renal disease, and decreased metabolism, for example, when a concomitant drug inhibits metabolism, or in hepatic insufficiency as with cirrhosis. These patients may require a decrease in dosage or less frequent dosing intervals. In contrast, the half-life of a drug may be decreased by increased hepatic blood flow, decreased protein binding or increased metabolism. This may necessitate higher doses or more frequent dosing intervals. Now, it is time to summarize the session. Using the knowledge of pharmacokinetic parameters, clinicians can design optimal drug regimens including the route of administration, the dose, the frequency and the duration of treatment. Here in this chapter, the basic knowledge of pharmacokinetics is also provided. Before moving to the next session, please try to answer the following questions. First, explain drug distribution. Next, discuss drug biotransformation, and next discuss the process of drug elimination. References: Lipin Code's Illustrated Reviews Pharmacology by Harvey, Richard A. and Pamela C. J.B. Lippincott, 6th edition, 1992. Davidson's Principles and Practice of Medicine, a textbook for students and doctors by P. Edward C.R.W. and Ian A.D. Boshier, Churchill Livingstone, 1992. Textbook of Medical Pharmacology by Uday Kumar and Padmaja, CBS Publishers and Distributors in 2004. The Pharmacological Basis of Therapeutics by Joel Griffith Hardman, Lee E. Limbird and Alfred G. Gilma, 10th edition. Rang and Dale's Pharmacology by Humphrey Rang and Maureen Dale, James Ritter and Rodflower, 6th edition. Pharmacogenomics, Challenges and Opportunities in Therapeutic Implementation by Yu Wing, Francis Lam and Larissa Cavalry in 2030. Thank you for watching this session. See you next time. Until then, bye.